I've heard a lot of misconceptions lately about how the body works, just basic muscle physiology, and I want to address it specifically as it relates to increasing knee flexion after a total knee replacement. I'm going to be talking to the audience who's 3 months or further post-op, not the acute knee, but 12 weeks and into the future, because now your incision is healed, hopefully the knee is starting to desensitize. You're dealing with what would be considered a true tightening of the connective tissue. And what I've been seeing online across social media from well-meaning therapists is they're saying your quad is too tight. So for reference, the quad muscle is the thigh muscle. Let me show you what I'm talking about. The quad muscle is the thigh muscle. It's the muscle that starts, it goes above the hip, below the knee. It's responsible for knee extension. And the theory is, well, if I can't bend my knee, it's because my quad is too tight. I think that's generally not the answer for most individuals after a total knee replacement. And a couple ways you can test this is if you flex the hip. So right now, just even sitting in a chair, the hip is about 90 degrees. That puts my quadriceps muscle in a relaxed position. If I still can't bend because of pain, discomfort, tightness localized here or on the inside, it's a connective tissue issue, not a muscle issue. And the way you can test this also is if you look at the other leg, the non-surgical leg. If you stand and you stretch, you feel pulling in the thigh, the quad. This is the muscle that you feel it. But most of my patients after a knee replacement, they feel it around the joint line, they feel it on the medial side of the knee most commonly. Occasionally they feel tightness on the outside. They describe a tight band sensation like duct tape or canvas wrapped around the knee, constricting it as they're trying to bend. They also talk about pain. These are very different from quad tightness. So if you're spending a lot of time trying to loosen the quad, massage the quad, all of these things to inhibit the quad, that's fine. It's not harmful, it's not bad, but it's not addressing the main root cause of the problem. I believe that most of the issue, and I've researched this a ton, most of the issue comes from a couple things. One is the size of the implant, the size of the spacer. And surgeons are going to choose the absolute best sizing for your particular situation. I've always said I would rather have a patient with a knee that's too tight than a knee that's too loose, because a tight knee can always be loosened, can always be stretched, can always be mobilized, but a loose knee really can never be tightened. The connective tissue, the ligaments, the surrounding structures, once they are too loose, they are always too loose. They can never be tightened back up. But when they're too tight, they can always be loosened. They can always be stretched. They can be mobilized. So a couple takeaways from today's video. If you absolutely believe the tightness in the quad is what's limiting your knee flexion, the best way to address that is by activating the hamstring. You know, our body is designed, muscles can only pull, they can't push. If I want to loosen one muscle because it's excessively tight, usually due to neurologic conditions or connective tissue, then I want to activate the opposite muscle, the antagonist. As I get my hamstring firing, it tells my brain to relax my quad. That's really the best way. Passive stretching is almost never an effective solution to lengthen or stretch a tight muscle. But after a knee replacement, I've been at this a long time. I've been a physical therapist since 2006. I still can't tell you that I've ever seen a patient who truly has a tight quad that's limiting knee flexion after a knee replacement. It's almost always the knee itself, the size of the implant, the size of the spacer, even scar tissue. I'm going to say, I think it's a false villain. I think scar tissue gets blamed way too often for maybe the choice of sizing. I'm trying to say this without offending. But if the surgeon puts in a slightly larger spacer, a slightly larger knee, you know, they always check your range of motion while you're unconscious in the surgical room before they close you up. But even with that, you're unconscious. As soon as you're awake and your brain is working, immediately there's going to be a guarding response, a fear response. And it's hard to know how that patient is going to respond once they're awake. So if they have a reflexive response to resist knee flexion when they're awake, it's much easier for the knee to heal and tighten in that position. There's lots of ways to address the connective tissue issue. My main hope for this video is I can relay some information to say, I'm not saying you're wrong. I'm just saying I haven't really seen situations where it's truly muscle tightness that's limiting knee flexion. It's generally connective tissue. It's generally pain. A lot of patients develop an itis, like a tendinitis or a tendinopathy that is, due to overuse, because before surgery you weren't doing a whole lot. Then you have a knee replacement and now you're exercising in some cases 2-3 times a day. You're developing overuse conditions associated with the rehab that you're doing. A lot of times I recommend patients do a little less. They take a little break. They give the tissue time to recover, time to repair. But these are all different video topics. You guys let me know what you want to hear about. I am happy to create the videos. In the meantime, we're getting ready for 2026. We're in the end of 2025. I hope you are moving toward your goals, even if you haven't achieved them yet. That's why they're goals, because they're out in front of you. Keep going, keep moving. I'll catch you guys on the next video.